As mentioned, as advertised, I want to use the time that I have to talk about some recent advances in our understanding and ability to predict and prevent suicidal behavior. So before getting started, or before jumping into some of the ideas and the data that I wanted to share, I wanted to take a step back and think about why it's important to focus on suicide. Why might you come out on a Wednesday night, midweek, to hear a talk on suicide? Why have I personally spent the past 25 years of my life, for nearly every day, thinking about this problem and trying to better understand it? At heart, it's because this is one of the most perplexing aspects of human behavior that has just really puzzled us as humans since the beginning of recorded history. It's a problem that for thousands of years was in the domain of philosophical inquiry, and over the years, virtually every major philosopher has written about the problem of suicide. Camus called this the one truly serious philosophical problem, and he went on to say, judging whether or not life is worth living is what he calls the fundamental question of philosophy. And although so many philosophers have written so eloquently about suicide over the years, it hasn't really made an impact on the suicide rate, and this continues to be an enormous problem. I can see by some of your faces you are not so into philosophy. Me neither. So we can think about this from a public health perspective. I know, me too, as a philosophy minor. Just now, Camus. Yep. So from a public health perspective, this remains an enormous problem. Data from the World Health Organization, for instance, indicate that there are about 1 million suicides each year around the world, which means one person takes their life around the world every 40 seconds. So every minute that we're here meeting tonight, another person will have died by their own hand. There are about 45,000 suicide deaths in the US each year, which might sound like a vague number if you don't commonly look at mortality statistics. To put this in perspective, that means that there are more than 5 times as many suicides as HIV/AIDS-related deaths each year in the US, more than twice as many suicides as homicides. And this last fact, more suicides than homicides, is true globally. So we hear a lot in the news, for instance, about wars and genocide and interpersonal violence, as we should. But what you may not have heard is that each year, there are more deaths by suicide around the world than there are by war, genocide, and all interpersonal violence combined, which means that we're each more likely to die by our own hand than we are by someone else's, which is, to me, a staggering statistic. Suicide in the US is the 10th leading cause of all death, second among our young people, second leading cause of death behind accidents among those ages 10 to 35. So second leading cause of death among our high school students, college students, and other young adults. And so for those of us who are parents, this is a big problem. And we're here in a high school today, and we know from data from national surveys of high school students in the US, like the Youth Risk Behavior Survey, that about 17% of high school students report that they've seriously considered suicide in the past year, with girls having about twice the rate of boys, and about 7% report that they've actually made a suicide attempt in the past year, again with girls having nearly twice the rate of boys. So for those of us who are parents, this is a very real, very concerning problem. And so I want to spend the time that we have tonight, and I'll try and keep my remarks to no more than an hour or so. I really want to leave a lot of time for questions so I can do my best to respond to and answer any questions that you've come here with tonight. What I want to do is spend the time that we have talking about some advances that we've made in the study of suicidal behavior. What I'm not going to do is sort of a cutesy TED-style talk that tells a just so story about why people die by suicide, frankly, because we don't know. As a scientist, as a clinician, what I want to do is try and help you, as I'm trying to help myself, understand why this behavior occurs. There's no good analogy there's no perfect analogy for suicide, but this is for many of us, a very scary, very real, very fatal, very perplexing process and outcome. I think of this often like the study of severe weather events. And we think about, for instance, the study of tornadoes or the occurrence of tornadoes, where for thousands of years these events occurred. They came out of nowhere. So you had some wind, you had some clouds, and then all of a sudden you had this really extreme event, this pretty rare event, but really fatal event that suddenly took the life of people around us. It wasn't until about 200 years or so, or 100 years or so, that we started to really understand why tornadoes occurred through systematic, careful observation, development of theories, and testing of them, that we now have early warning systems, ways of predicting, not preventing tornadoes, but preventing loss of life due to them. We can think of suicide in a similar way, in that we're pretty early on in our science of suicide. And so what we have is the beginnings of some pieces of the puzzle. We're not able to put them together, so I'm not going to try and put them all together with you here tonight. But what I do want to do is arm you with information to try and demystify the problem of suicide and try and arm you with recent scientific findings and some practical information about what you can do if you or other people might be struggling with suicidal thoughts. How can we detect these thoughts? How can we predict what a person might do? How can we help them as best we can? Statistically speaking, we're all, if we haven't already, going to encounter suicide in our lives in some way. And so a big part of my goal tonight is trying to arm you with information that you find helpful in such encounters. So what I want to do is spend some time talking about 5 things. I want to talk a little bit about what this is, what the problem, what suicidal thoughts and behaviors are. I want to talk about who's at risk, what groups are most at risk, what are the most important risk periods. I'll spend a little bit of time talking about some thinking about why people become suicidal and why they engage in non-suicidal self-injury, cutting and burning and so on. I'll talk a little bit about how we can best detect and predict suicidal thoughts and behaviors, sharing both some recent, I think fairly exciting scientific advances, but also some practical advice that you can use, starting today, starting tomorrow. And I'll end by talking about how we can prevent suicide. Similarly, by talking about some recent scientific advances that will have implications moving forward, and I think there's certainly hope, but also arm you with information about what you can do today, tomorrow, to try and help those around you. I'll spend a few minutes talking about each of these, again, and try and save a lot of time for questions if you have them. So first, thinking about what are suicidal thoughts and behaviors. As you know, suicide is the act of intentionally ending one's own life, and I'll talk about some of what we know about suicide. But over the past years, we've started to get traction in our understanding and prediction by thinking about some related behaviors, and I'll talk about each of these tonight. So I want to make sure that I'm clear in terms of what I'm talking about. We've started to study some of the sort of signposts leading up to suicide, and these are for intermediate behaviors of the following type. We focus on suicidal thoughts, or as clinicians sometimes say, suicide ideation. Ideation just being a fancy made-up word for thoughts. So it's just having thoughts of intentionally ending one's own life. A person might progress to having a suicide plan or a formulation of a method and some intention of acting. We study suicide plans because having a suicide plan statistically significantly increases your likelihood of making a suicide attempt. And a suicide attempt refers to some self-injurious behavior with some non-zero intention of dying. And I say non-zero because, as I'll discuss, there's often ambivalence in people's decision to make a suicide attempt. I'll spend a little bit of time also talking about non-suicidal self-injury, which refers to self-injurious behavior with no intention of dying, often taking the form of cutting or burning the skin. And this is a behavior that's been around for a very long time, but it's only been the past few years that we've started to get a better understanding of why people engage in these behaviors. So these are the set of behaviors that I'm going to talk about over the next hour, and I'll do my best to make distinctions about which I'm talking about at each point in time. So I want to transition now to think about who is at risk for each of these behaviors. What have we learned about high-risk people and high-risk periods? I'm going to start really broad and then narrow in. At the broadest level that we could possibly go to as being humans, this is the suicide rate around the globe, portrayed here, with darker colors indicating higher risk. And we see no discernible pattern, or I see no discernible pattern here. There's higher rates in China and Eastern Europe, lower rates in Northern Africa and some parts of the Middle East. Important for us here in the US. The US is sort of in the middle of the pack in terms of suicide rates. We don't have a good understanding of why this variability exists, but it's pretty consistent. Within the US and around the world, we see pretty strong sex differences. I mentioned earlier that for things like suicidal thinking and suicide attempts, girls report much higher rates than boys. But for suicide death, in virtually every country around the world, men die by suicide much more often than women by a ratio of about 4 to 1. And these are data from the Centers for Disease Control here in the US, and we see this difference is pretty consistent across the past 15 or so years. You might notice that the suicide rate over the past 15 or so years has been increasing, and this gets written about a lot in the media. People say there's a suicide epidemic. Important, and the rate has been increasing pretty consistently over the past 15 or 20 years. Important context, though, the rate decreased for the 15 or 20 years before that. I think the more important thing to consider here is the suicide rate in 2016, the most recent year for which data are available, is virtually identical to what it was in 1916. And this is very different than what we see for other leading causes of death. If you look at mortality data for things like pneumonia, cancer, tuberculosis, accidents, over the past 100 years, the rates of death from these problems have decreased dramatically due to advances in science and medicine. This is not the case for suicide. We see some ups and downs, but the rate has been pretty flat over the past 100 years for which we've been keeping data. And we're hopeful, though, that with advances in science, we'll start to turn this curve down a little bit. We also in the US see pretty consistent racial and ethnic differences and age differences. Shown here are, again, data from the CDC and the American Foundation for Suicide Prevention. If you can't read this figure, this is going from left to right across the past 15 or so years. The blue line on top is for people who are classified as being white. And in fact, in the US, pretty consistently, about 90% of suicides are among white people. And combining this with the previous slide, about 70% of all suicides in the US are among white men. We don't have a good understanding of why. We also see pretty consistent age differences. Each bar here is a different age group. The ones to note that really stand out are this blue line, where we see a really low rate. This is for people less than 15 years. So suicide as an outcome is pretty rare in people who are less than 15 years. It's very rare that children or young adolescents will die by suicide. The next line is those 15 to 24 years, and it's approaching the rest of the other years of life. Although suicide death is pretty rare in adolescents and younger adolescents, rates of suicidal thoughts and behaviors we think are more common. But we haven't really known whether that's the case or not, in part because whereas the CDC, the US government and other governments around the world keep pretty good data on suicide death. If someone dies by suicide, they document the race, sex, and age of the person, but we don't know much beyond that. And this is an ongoing problem in the study of suicide. The person who we're interested in studying, of course, has passed away, they're dead, and so we can't know very often what led up to their death. And so we want to study suicidal thoughts and behaviors, but we don't have good data on them because they haven't been carefully and systematically studied over the years, and so we don't know, we haven't known until fairly recently, how often do these things occur? What's the rate in our community? What percentage of people think about suicide, make a suicide plan, make a suicide attempt? When do these things tend to begin? How do they change over time? What are common risk factors? People have done studies over the years, but they've been really small, selective studies. So for instance, we've done studies, and others have done studies, using 200 middle school students in Boston, or 500 high school students in Los Angeles, or 300 college students in Chicago, and so on. And it's really hard with these somewhat small and non-representative samples to make generalizations. So to try and learn more about suicide, our research group, in combination with a number of other research groups, have done what we believe to be the largest, most representative study of suicidal behaviors ever done. And what we did was team up with our colleague Ron Kessler at Harvard Medical School, who conducted a study in the US called the National Comorbidity Survey. And this is a big representative study of about 10,000 people who are randomly selected from around the US, and interviewers go to their house and interview them and ask them questions about whether they've had thoughts of suicide, whether they've made suicide plans, whether they've made a suicide attempt, and they ask about a range of other factors. And this is a study from which we get information about what percentage of people have depression and anxiety and alcohol use and so on. This study was replicated in nationally representative samples in countries across the Americas, Europe, Africa, Asia, and the Pacific. Each of these 24 or so countries did a very similar study, sent their data over to Harvard Medical School for analysis, and from this we've begun to learn about what suicidal thoughts and behaviors look like in our community. For instance, what percentage of people, of all adults randomly selected from the population, say that they've seriously considered suicide at some point in their life? Any guess? What percentage of people have thought about suicide? 15, 50, 25. 9% of people, this is pooling data from across 17 different countries, 9% of people have seriously considered killing themselves, 3% have actually gone to make a plan, and 3% say that they have attempted to kill themselves. You'll see on the right, these rates vary pretty dramatically across countries, as do suicide mortality data. We don't know why. The US with New Zealand is pretty consistently in the highest rate here, with 15% of people in the US thinking about suicide in their life, 5% making a plan, 5% making an attempt. Although the rates of these outcomes vary pretty dramatically around the world, once someone says they've thought about suicide, suicidal thoughts and behaviors look pretty consistent in every country we've examined so far. They look consistent in when they have their onset. So when we look at across these 17 different countries, when does risk of first starting to think about suicide increase? What we see is great consistency. So each of these lines is a different country. I encourage you not to try and figure out which line is which country. What I want to point your attention to is the fact that on the horizontal axis here, this is year of life. On the vertical axis, this is risk of starting to think about suicide. We see no thoughts of suicide, or virtually no thoughts of suicide in childhood. In every country we examined, the risk skyrockets in adolescence. Something about adolescence, about pubertal development, about the transition to adulthood, triggers this huge spike in suicidal thinking. We also see consistency in the probability of transitioning from suicidal thought to action. Across countries, in virtually every country we examine, about a third of people who think about suicide will ever make a suicide attempt, which is an important fact to know. If someone you know is thinking about suicide, they've got about a 1 in 3 chance of acting on those thoughts. 2/3 of people who think about suicide will never make a suicide attempt. The speed of that transition also is pretty consistent around the world. So how long in years does a person go from when they first start thinking about suicide until they make their first suicide attempt, if they're going to? This is shown from left to right. So this is how many years pass from when a person first starts thinking about suicide until they make a suicide attempt, if they do. And what this figure shows is, in every country we examined, 60% of the time or more, if a person's going to make an attempt, they make it in the first year after onset of suicidal thoughts. So that first year after a person starts thinking about suicide is the highest risk time for their first attempt. The longer a person goes thinking about suicide without making an attempt, the less likely they are to do so, which is a little counterintuitive. You might think that if someone's thinking about suicide for many years, they're more and more likely to make an attempt, but the opposite is the case. It may be that some people think about suicide, but they've got good impulse control, good social support, or something related. Now, the question of what the pathway to suicide looks like is a common one. So we drilled in and wanted to investigate this a little bit more to see when a person makes a suicide attempt, shown on the right here, what does that pathway look like? And so we've interviewed a lot of people who've made suicide attempts and said, when did you first start thinking about suicide? And that's plotted in this light box over here. It's a few years out. Each of these boxes is the median or 50th percentile point. The dotted line represents periods of not thinking about suicide. We next see that when the person had an onset of suicidal thinking related to the current suicide attempt, it tends to happen about 2 weeks out. So before a suicide attempt, if a person's thought about suicide in the past, about 2 weeks before, their suicidal thinking increases. This next darker box is for mulling. When do you really start mulling over the decision to try and kill yourself? It's about 6 hours before. And about 5 minutes before, on average, people say that they make a decision that they're going to make a suicide attempt. And thinking about what method you might use to make a suicide attempt, again, people are thinking about a method for the first time 5 years ago, but it's really only about 2 hours before an attempt that they really start thinking about how they're going to do it and where they're going to do it. And so in one sense, often there's the beginnings of suicidal thinking a year, 2, 3 years out before a person makes an attempt. But things really start rolling in terms of suicide thinking and planning in the 6 hours or so before a person makes a suicide attempt. On the positive side, there's some time here for people to intervene. On the more concerning side, 6 hours is not a huge window. So if someone you know is at risk for suicide, it's important, I think, to check in on a regular basis is what these data tell us. And I'll talk in a little while about how we're trying to do that. We also see consistency in risk factors. So, as I mentioned earlier, being male increases your risk of suicide death, but being female greatly increases your risk of thinking about suicide and making suicide attempts, as does being younger, as does being unmarried, as does having a mental disorder, like depression or anxiety or a conduct disorder or substance use disorder. And in fact, over many decades, data have showed us that about 90 to 95% of people who die by suicide have a diagnosable mental disorder before their death. Not necessarily diagnosed, so it's not necessarily known, but by interviews and by record review, 9 out of 10 people had a diagnosable mental disorder. And having 2 or 3 or more disorders especially increases a person's risk. Why might this be? Well, with this large sample, we dug into the data and said, if we look at, and I'm not going to show you them all here, but we looked at 16 different mental disorders at once to see which disorders predict suicidal thinking. What disorder would you think would be the strongest predictor of thinking about suicide? Depression. If we do a word association game and someone says this person's suicidal, the first thing you might think about is depression. And so we looked at 16 different disorders at once and tested which is the strongest predictor of suicidal ideation, and it turns out depression is the strongest predictor. What I'm showing here are odds ratios. So what these are essentially showing are what's the increase in the odds or likelihood of this outcome, suicidal thinking, if you have a prior depression. Having depression doubles your odds or doubles your risk of thinking about suicide compared to about a 50% increase for these other disorders. So depression is really important for a person to get a person thinking about suicide. Now, among those who have suicidal thoughts, what predicts whether a person acts on those thoughts? There, depression does nothing. An odds ratio of 1 means they're no greater or less likely to make a suicide attempt. What does predict acting on your suicidal thoughts are disorders characterized by anxiety, behavioral problems, substance use problems, which we think is why having 2 or more disorders at once really increases a person's risk. Putting this together, depression might get you thinking about suicide, but other disorders might get you acting on your suicidal behavior. There are other risk factors to know about and to consider, and looking over the past 50 years of research, we've recently found a range of different risk factors. This blue line here shows an odds ratio of 1, so things above this line are represent increased risk. I will not go through what all of these risk factors are. They're things like having a family history of suicidal behavior, having stressors in your life, having a medical condition, and so on. The point here is these are our strongest risk factors for suicide. The strongest one we see is for being in treatment. Being in treatment is associated with greatly increased risk of suicide death. Not because treatment kills people, but likely because people who are really at risk get themselves into treatment. That's why we see that strong association. Outside of that one, all of our strongest risk factors are just above an odds ratio of 1, which means there is no one risk factor for suicide. There's no one thing that does it. There's no silver bullet. Each of these risk factors ticks up your risk just a little bit. And so we think the best way to predict suicide and suicidal behavior is to combine information about a lot of these risk factors, each one having a small effect. And when we try and do that, we see evidence for this approach. The more risk factors you have, the greater your risk of suicidal behavior. And in one study about 10 years ago, we did this. We got a large sample of people who were thinking about suicide, and we simply added up their risk factors. We measured 12 different risk factors that are associated with suicide attempts, and we said, among this sample of people who are thinking about suicide, how many risk factors do they have? And we put them into bins of those we considered to be at low risk. They had 0 to 3 out of 12 risk factors. That was 19% of our sample, and none of them made a suicide attempt over the next year. People who had 4 to 6 risk factors. That was 50% of our sample, half of the people. Only 3% made a suicide attempt over the next year. Those who had 7 to 9 risk factors, 16% of our sample, almost a quarter of them made a suicide attempt. Those who had 10 to 12 risk factors, 13% of our sample, smallest group, but 8 out of 10 of them made a suicide attempt over the next year. And that group represented 2/3 of all suicide attempts, highlighting that a strong way, a good way to predict suicidal behavior is to simply measure a broad range of these risk factors, important risk factors, and add them up. A pretty crude, simple, additive model. More recently, we've replicated this across 21 different countries, so it is a pretty reliable finding. And more recently, we're capitalizing on advances in technology, something I'll talk a little bit about tomorrow. We're using larger data sets that are now available from things like electronic health records that are now kept, and we're using fancier models in addition. We're using things like machine learning, statistical learning to go across big samples of data to pull out lots of variables and combine them in ways that give us stronger predictive accuracy. The idea being one of our strongest ways to identify people at risk right now is to measure a really wide range of risk factors and to study them in combination. So this is a little bit about who is at risk for suicidal behavior. I want to transition to talk a little bit about why people kill themselves, what we think about why people kill themselves. And this is, full disclosure, going to be the briefest and probably least satisfying part of this talk, in part because we really don't know, to be frank, why people kill themselves. But I wanted to share with you what some of our conceptualizations have been about why people become suicidal. From the earliest study of suicide, by sociologist Emil Durkheim, we had the idea that suicide results from a breakdown in social integration. And this idea makes sense. If you are disconnected from others, for instance, this could lead you to feel really isolated, disconnected, like you don't belong, and this could lead to suicidal behavior. Later on, everyone's favorite psychiatrist, Sigmund Freud, suggested that there's a strong emotional component, that if you're angry at someone else and you're unable to express that emotion, you turn it inwards and attack yourself, and that is where suicide comes from. And of course, there is evidence that there's a social component involved, and that social isolation and social stressors play a role. There's evidence that strong emotion and anger and aggressiveness is also a risk factor for suicide. Slightly more recently, with the cognitive revolution in psychology, there were a number of studies on cognitive components like rigidity. Nuringer and others did studies showing that when people are in a suicidal state, they think differently. And this is true, and this has been shown up till today. People tend to be very rigid in their thinking when they're in a suicidal state, and their thinking tends to change, and they're less rigid when they're out of a suicidal state. And Nuringer and others have shown this even with simple tests like, how many words can you think of that start with the letter F? And when people are in a suicidal state, they have blinders on, so to speak, and they're just not able to think very flexibly. And when they come out of that state, they can think more flexibly. So there's some evidence for this as one component of where this risk comes from. One of the most popular theories, and I think one of the most well supported by Edwin Schneidman, suggests that people become suicidal and try and kill themselves as a way to escape from intense psychological pain. And why, for me, some of the most convincing evidence of this comes from interviews of people who have tried to kill themselves. If you talk to people in the emergency room, in the hospital, after they've made a suicide attempt and say, why did you try and kill yourself? The number one reason people give is, I wanted to escape from some seemingly intolerable circumstance, whether it was intense emotion, humiliation, isolation, depression. So often people say, I didn't want to die, per se, I just wanted to escape from what I perceived to be this really painful situation. And there are newer theories since the 90s that combine different parts of these models, that combine social factors with emotional factors, with psychological factors. I'm not going to go over them in detail because to date, none of these has really predicted this outcome with a high degree of certainty, so I don't want to suggest that there's any one model that you should know about. But these different types of factors certainly seem to play a role. Again, there is no one factor, there are no two factors, there's no simple explanation for this outcome. I don't want to reduce it to that. This is, again, a rare outcome that we think is a result of a complex interaction of lots of different stressors and factors and traits in a person's life. And if you want, in the Q&A, we can talk about genetic risk and other biological risk factors and psychological risk factors and what might play a role. And figuring out what components are involved and how and why they combine to lead a person to think about suicide in some instances and to act on those thoughts in other instances is something that we're actively trying to tease apart in our research. I also want to say a little bit about non-suicidal self-injury, which has been getting more attention in the media and in the literature, I think because we're seeing an uptick. There's not good evidence in the data of an uptick in in non-suicidal self-injury, which refers to, again, direct, deliberate destruction of body tissue in the absence of any intent to die, often taking the form of cutting or burning and the like. There haven't been good surveillance data. CDC and others haven't tracked this over the decades, and so we don't know if this behavior is increasing. But from being a researcher and a clinician, and from talking to parents and teens and school nurses, this seems to be on the rise. And we're seeing rates now in adults ranging from 1% to 4% in the community, with slightly higher rates in clinical samples, to much higher rates among adolescents in self-reports among high school students and college students. Why might people engage in self-injury? Well, like suicide, this is a behavior that's been around since the beginning of recorded history. Early explanations going back to the Bible talked about demon possession. That's what's often invoked in cases of early understandings of mental illness and related problems. There are early psychoanalytic accounts that also suggested that self-injury, like suicide, is a result of anger, that this is a way of boundary definition. If I cut myself, I'm showing that this is my body and it's separate from my mother's body, and so on. Very interesting explanations without a lot of data. For decades, suicide and self-injury have been viewed through a psychiatric lens as being the result of mental disorders because, as with suicide, many people, the majority of people who engage in self-injury, have a mental disorder, a diagnosable mental disorder like depression or anxiety or borderline personality disorder. But I would argue this is not very explanatory. because many people who engage in self-injury have a diagnosable depression, that doesn't explain why they're engaging in self-injury. Because they have depression doesn't quite do it. Most people with depression don't engage in self-injury, and this isn't a strong causal model. The good news is that over the past decade, 20 years, there's been a huge uptick in research on suicide. This is the number of articles published each year on non-suicidal self-injury from the 1920s all the way jumping up into the 2000s. We see about 100, 200 papers per year. And over the past 15, 20 years, the rate of research on this topic has skyrocketed. And we've learned a lot. And one thing I want to share is one potential explanatory model for self-injury that's been supported with a really good amount of behavioral and experimental and psychophysiological research. And this is the idea that young people engage, and older people engage in non-suicidal self-injury because it is reinforcing in some way. You may remember, if you've taken intro psych, what reinforcement refers to. This is a process through which behaviors are rewarded and are repeated. And reinforcement, as a reminder, can take the form of being positive or negative in nature. Positive reinforcement refers to an increase in the frequency of a behavior following the presentation of a favorable stimulus. Plainly, if you open a door and millions of dollars falls out, you're going to open that door a lot of times. You are presented with some favorable stimulus. Negative reinforcement, not to be confused with punishment, also refers to an increase in the frequency of a behavior, but following the removal of some aversive situation. For instance, it tends to be cold in Chicago, from what I understand. If you go outside, you're cold, that's an aversive state. You put a jacket on, the cold goes away. That's negative reinforcement. You are reinforced by this behavior that took away something that you didn't want. So that's a positive reinforcement process and a negative reinforcement process. And the contingencies, the consequences for these behaviors could be internal or intrapersonal or external or interpersonal. And so, for instance, a person might engage in self-injury for internal negative reinforcement to get rid of some really bad thoughts or feelings. And this is, in fact, the number one reason that people give for engaging in self-injury. I feel really bad, whether I have really bad feelings or really, really bad or aversive thoughts. I cut myself, I burn myself, and those thoughts and feelings go away. How? We're not quite sure. We don't know if the mechanism is simply the fact that distraction, that pain demands attention, and so if you're having a bad memory, a traumatic memory or experience, and you cut or burn yourself, your attention goes to that cut or burn, and so the memory goes away, or you stop focusing on it. Maybe it's the release of endorphins, maybe it's activation of the parasympathetic nervous system. There's evidence for each of these things. We also see evidence in lab-based studies that if we bring adolescents into the lab, self-injurers and non-injurers, and we stress them out, I will tell you later how, if you are interested. We see self-injurers have much stronger emotion reactivity, physiologically, objectively, especially those who say that they engage in self-injury to get rid of aversive feelings. They do have this really strong emotional response to stressful events. So there's some objective validity for these reports. A person might, in contrast, engage in self-injury for internal positive reinforcement. About 25% of the time, when adolescents cut or burn themselves, they say it's not for negative reinforcement, but positive reinforcement. I feel nothing at all, and I cut or burn, and it feels good. It brings me pleasure in some way. And people might also engage in self-injury for social or interpersonal reasons, such as interpersonal positive reinforcement, to elicit help from others, to get access to attention or resources, or for social negative reinforcement, to get rid of some aversive social event that I don't want, to get kids to leave me alone, to get my parents to stop fighting, to get out of having to go to mom's house or dad's house or something of the like. We have evidence of these through self-report, through behavioral studies, through psychophysiological studies, and so on. I don't want to or mean to suggest through these social functions, these interpersonal functions, that if a person is engaging in self-injury, they're only doing it for attention. These social or interpersonal functions seem to be in play only a small percentage of the time. I'd also argue that if someone's engaging in self-injury to elicit help from others, and they're going so far as to cut or burn themselves or insert objects under their skin to elicit help from others, they're probably in need of help from others. So there could be some benefit to attending to that signal of distress. But this model hopefully will help understand behavior a little bit, and it's been used to help us develop and implement treatments to try and drive the behavior down. So I want to transition now in the final part of my talk to talk a little bit about how we can best detect and predict and then prevent suicidal behavior. So what do we do how do we detect suicidal thinking? We know from decades of research that about 2/3 of people who die by suicide, importantly, told someone before they died that they were thinking about death or suicide. And so the strong message here is, and if you take nothing else from this talk, I hope that you'll take this: if you suspect that someone might be thinking about suicide, please ask them. Again, in the majority of time, 2/3 of the time, people are sending signals out. It's often scary to ask someone about suicide. There's often a fear that if you ask this question, you're going to put the idea in someone's head if they weren't thinking about it. There's actually good experimental evidence showing this is not the case. There have been studies done. Madeline Gould at Columbia University published a paper in the Journal of the American Medical Association a few years ago showing she did an experiment in the New York public schools, randomly assigned kids to be asked about suicide if they're suicidal versus not, and then ask questions about how distressed they were, and then ask questions about whether they're thinking about suicide. Kids who were asked about suicide were no more distressed and no more suicidal than kids who weren't asked about it. Being asked about suicide does not make you suicidal. Trust me, I've been asked about suicide for 25 years, virtually every day of my life. I'm not suicidal. We talk with people about it every day. It does not lead people to become suicidal. It's a myth that's out there, and it's been pretty strongly debunked by science. I understand the concern. It is a scary topic to talk about. It is uncomfortable to talk about, but I would suggest it's more uncomfortable to not ask about it and to miss an opportunity to intervene. And to talk with people about it also sends the signal that it's okay to talk about. It is okay to ask this question. It is okay to discuss it. And you send a signal that you're someone who's okay talking about it. So if someone is struggling, they can come to you and ask you about it. How do you ask about it? How do we train clinicians to ask about it? In a calm, dispassionate way. And we encourage people, if they're not comfortable in asking about suicide outright, to lead up to it with softer questions. You seem like you've been pretty sad recently. What's going on? Have things been so bad? Are things so bad that you've thought about dying? Have you had thoughts of actually hurting yourself? Have you had thoughts of killing yourself? So you might lead up to it with these softer questions if you are so inclined. If you know someone who might be struggling, I would encourage you to practice asking these questions, practice looking in the mirror, practice with someone else. I know, as someone, as a researcher, as a clinician, as a father, as a brother, as a son, these are things, as a friend, these are things that are difficult to ask about. I've asked others, I've asked friends, I've asked family members these questions. To me, who's been doing this for 25 years, it's still tough to ask the question to people, but it's important. And I've been surprised, and I'm continually surprised at how helpful it can be to ask people about this. So I really, really strongly encourage you to do so if you find yourself in a situation where you even suspect that someone might be having a thought about suicide. What we teach clinicians is to assess when they have someone who says that they're thinking about suicide, and I'm not going to get too much into this, but I want to sort of demystify what clinicians do, is to assess how strong is a person's desire to die. Does the person have a plan to kill themselves? Because that's been shown to be predictive of making a suicide attempt. And how strong is their intention of acting on their suicidal thoughts or acting on their plans? And clinicians will often use the answers to these questions to make determinations about, is a person safe enough to continue to be out in the community? Should they be brought into the hospital for further observation, evaluation, and so on? And I'm happy to talk more about that if you're interested at the end, about what the process is like, and again, trying to help demystify how suicide risk assessments are done and how suicide is detected and treated. One thing that we've struggled with as researchers and as clinicians is the fact that although it's important to attend to suicidal thoughts and to ask people about suicide, that's an incomplete approach. It's incomplete because if we rely on self-report, things can go wrong, things can be problematic, because although we should take people seriously if they tell us they're thinking about suicide, many times people are motivated to deny or conceal thoughts of suicide for fear of being intervened upon, of being hospitalized against their wishes, and so on. We also know, from data that I'll show you in a few minutes, suicidal thoughts tend to be episodic in nature often. And so they may be absolutely present one moment and absolutely not present hours or days later. We also know from decades of work in psychology that we all lack conscious awareness of factors influencing our behavior, and we are really poor predictors of our future behavior, all of us. And this is the case for suicidal behavior as well. We know this because although 2/3 of people who die by suicide told someone else they were thinking about suicide before they died, on the other hand, nearly 80% of people who die by suicide explicitly denied suicidal thoughts and intentions in their last communication before dying. And so, as I mentioned earlier, there's often a lot of ambivalence involved in the minds of people who are thinking about suicide. And so on one instance, they may genuinely say, I'm thinking about suicide, and in another very near-term instance may say, no, I'm not thinking about it anymore, or I'm not going to do it. What we really need, we think, are some objective tests, some behavioral markers of suicidal thinking, some methods that can measure how a person's thinking about suicide without relying on their self-report. For instance, we have a person in front of us who's saying, I don't want to kill myself. What we want to know is, what is that person thinking that they may not be telling us? Whether they're unspoken thoughts or they're implicit cognitions, as we call them, things that aren't reliant on conscious introspection and explicit self-reporting. Implicit cognitions, the content of our thoughts, are things that we all have wanted to know since the beginning of time, right? I wonder what you're thinking, you wonder what I'm thinking, I wonder what my students are thinking, what my kids are thinking, what my wife is thinking, what my patients are thinking. Fortunately, over the past few decades, psychologists have developed ways of measuring what a person is thinking about and how a person is thinking about things using not what they say, but what they do, using their behavior, using tests of memory, using tests of reaction time. For instance, there's a test called the implicit association test. Has anyone heard of the implicit association test? Just one person. So this is a brief reaction time test that asks you to classify things on the left side of your screen versus the right side of your screen, and we use your response time to measure how you're thinking about different topics. It looks like this. For instance, in the interest of time, I'm not going to go through a demo, but in the Q&A, if you're interested, I'm happy to do so. You're seated at a computer screen, and it turns out that humans are faster at classifying things. If I give you 2 buckets, and I say classify these 2 kind of things and those 2 kind of things, seashells and rocks or sticks and plants, you're faster at classifying things that are like each other, that you associate with each other. You're slower at classifying things that are not like each other in your mind. So if we show you words related to death or life, and dead, dying, suicide, living, thriving, surviving, and we show you words related to you, me, and not me, I, me, mine, they, them, theirs, and ask you to classify them, for instance, you'll see the word suicide pop up. This goes on the left because it's a death-related word. And we ask you to classify words that appear in the middle of the screen, and we measure your response time in milliseconds. Sometimes we pair death with me. Other times, we pair life with me. And what we think is, if you're somebody who's suicidal, you identify with death. You put death like me, like yourself. If you're not suicidal, you're faster responding when life and me are paired together, because those are more alike. And so we show words in the middle of the screen, have people do the classification. Again, I can show you an example if you want to get a better sense of this. It takes about 3 minutes to do, and we test it out. Does this test distinguish between the people who are suicidal versus those who are not suicidal? To see how clinically useful this is, we set up shop in a local emergency room and gave this test to people as they came through the emergency room. And it turns out there's huge differences in people who are faster responding when they are pairing death and me together than those who are faster responding when they pair life and me together. People who are faster responding in milliseconds when death and me are paired have 3 times the rate of making a suicide attempt after they leave a psychiatric hospital. And performance on this test, which we can administer in 3 minutes, outperforms clinician prediction at predicting suicide attempts. Clinicians, I'm a clinician, we are no better than a coin toss at predicting which patients are going to try and kill themselves. Patients, we ask them themselves in the ER, are you going to make a suicide attempt in the 6 months after you leave the hospital? Patients can predict better than their clinicians can, but this test was a stronger predictor than clinicians and patients were. We observed this effect in the general population. If anyone's interested in taking this test or others like it themselves, we have a website called implicitmentalhealth.com. And you can go to this website and you can take implicit association tests, these quick 3-minute tests about suicide, self-injury, anxiety, depression, alcohol use. Are people who have mental disorders violent? So violence is paired with mental disorders. The tests rotate, so there may or may not be suicide or self-injury ones there now. If not, go back. They change from time to time. We use this website as a way to inform people about implicit cognition and its role in our thinking and behaviors, but also as an anonymous data collection site. And we've shown very similar effects in the general population with significant differences between suicidal and non-suicidal people on tests like this. And a nice advantage of this test is it's objective, it's quick, it's portable, it can be administered on any computer, on any smartphone. And so what we're doing now is going out into the community, or putting these tests on people's phones and measuring how they're thinking about suicide in the months repeatedly after they leave the hospital to see, can this give us a good local predictor of a person's risk? We're also looking for neural markers, brain-based markers of suicide risk. Again, the goal here is to identify objective markers, to have quick tests that can be used to identify people at risk. And we recently have found evidence for this, drawing on the work we did on the implicit association test, where people pair the idea of death and me when they're suicidal. Turns out that suicidal people, their brains respond differently to suicide and death-related words than to the brains of people who are not suicidal. So this is work done with Marcel Just and David Brent and others, some colleagues in Pittsburgh, where the research team put into fMRI, into brain scanner, suicidal adolescents and non-suicidal adolescents, and showed them words from our implicit association test and otherwise, and found that people who are suicidal, their brains responded differently to these words. And in particular, we saw activation in areas of the brain associated with self-referential thinking. So in the IAT, we show words like death and me, and people pair them together quickly. And the brain scanner, we show words like death, and areas of the brain associated with me, associated with the self, are more active in suicidal people than in non-suicidal people. And when we use machine learning methods to classify these responses, we see really clean differences between those who are not suicidal and those who think about suicide. And using just their neural responses, we can classify suicidal and non-suicidal adolescents with about 90% accuracy. And we compare those who thought about suicide versus those who have made a suicide attempt. We can make those classifications with about 94% accuracy. And these effects are replicated in a second sample. So the first study, the IAT study, provides some objective way of using a person's behavior to detect risk. This uses an objective way of using neural responses to identify risk. To be clear, this is not yet clinically tractionable. I'm not suggesting that if we want to know if someone's at risk for suicide, we put them in a brain scanner. It's a pretty accurate way to make these distinctions, but it's also very time-consuming and very costly. But a really, to us, surprisingly powerful way of detecting and trying to get a better understanding of suicidal thinking, which we hope will lead us to better ways of preventing suicidal behaviors. And this is the last thing I'm going to talk about today. How can we, if we believe someone's at risk, what can we do to try and help them? So what can we do to prevent suicidal behavior? And a lot of what I say is going to be relevant for non-suicidal self-injury as well. Again, starting with practical advice. If suicidal thoughts are detected, I would strongly, strongly encourage you to get help from a professional as soon as possible. So a lot of times when we as members of society encounter people who are suicidal, we try and shoulder a lot of the burden and a lot of the care and a lot of the responsibility ourselves, and it's a lot for someone to take. I would, as a scientist and clinician and person working in this area for a very long time, encourage you, if you know that someone is thinking about suicide, don't do this all yourself. Get them to help. Get them to a professional. An easy way to do that, an easy first step for anyone, either someone with suicidal thoughts or someone close to someone with suicidal thoughts, is to call a hotline like 1-800-SUICIDE, which is a toll-free, nationwide, anonymous hotline. You can call if you're thinking about suicide. You can call them and say, hey, my friend or family member is thinking about suicide. Please help me figure out what I can do. You can walk someone or take yourself or someone you know to the local emergency room. And for those who haven't been to an emergency room for psychiatric reasons, these work very much like if you need stitches or have a broken bone. You present to the emergency room and you say, I'm having thoughts of suicide, I'd like to talk to a clinician, or my friend or family member is having thoughts of suicide, can we see a clinician? And a psychiatrist or nurse or psychologist or social worker will come out and do an interview and help figure out what's the best course of action. It is not always to bring that person into the hospital for an overnight stay. It is often, let's connect you with an outpatient clinician, let's have you go home and here are some resources and some things you can do until you can be seen tomorrow or the next day or the next day and so on. We're not yet at the point where we're using tests like the implicit association test or brain scanning to make these determinations. We're just finishing a study where we use the IAT machine learning methods, as I described earlier, on a sample of 2,000 people passing through the ER to try and develop a risk calculator to get better at making these determinations, but we're not quite there yet. It's not quite ready for deployment. In less severe cases, less acute cases, one of the treatments that you might be referred to, or a person might be referred to, are one of the frontline psychological interventions. There are psychological treatments that have been developed and tested and shown to be effective for people with risk for suicidal thoughts and behaviors, such as dialectical behavior therapy or cognitive behavior therapy, or as they're referred to, DBT or CBT. These are talk therapy approaches, face-to-face, generally once a week approaches, but they are manualized, meaning the people who developed them came up with a pretty specific manual on what to do session by session to, for instance, in the case of DBT, remember I mentioned the functions that self-injury can serve. People may engage in self-injury or suicidal behavior to escape from really aversive thoughts or feelings. They have trouble tolerating them, so they want to escape from them. So DBT says, let's teach people how to tolerate severe distress. Let's teach people emotion regulation skills. Let's teach people interpersonal skills to deal with some of those social motivators. Let's teach people mindfulness skills so they can not only tolerate their negative affect, but really appreciate the positive affect and positive things in your life. DBT has once a week with your individual clinician, once a week with a skills group that teaches these skills, and 24-hour access to your clinician to help you use the skills when you need them most. And these treatments, relative to other treatments, have been shown to decrease risk of suicide attempts by about half in people who get these treatments versus other treatments. So they have shown some evidence for their effectiveness. How can you find them? I will share with you what I do when I try and find treatments for friends and family. I go to this website. It's managed by National Association of Clinical Psychologists called the Association for Behavioral and Cognitive Therapies, but their website for therapist finder is findcbt.org. Find a therapist, FAT. You can go anyone can go onto this website from a web connection, type in a zip code, type in, do you want to see, is it a child, is it an adult, is it couples therapy, is it for depression, is it for anxiety, is it for suicide risk? And they give you somebody who's affiliated with the Association for Behavioral and Cognitive Therapies. I can't and they can't vouch for how effective the individual person you're hooked up with will be, but it's generally, if they're in this group, they're a person who's connected to approaches like these in some ways, and so it's, for my money, a much more effective way to go than opening up the yellow pages, for those who remember what the yellow pages are. And an important part of CBT and DBT are really careful monitoring and risk assessment. Both have strong components of not just saying, hey, it's unfortunate to know that you're struggling with thoughts of suicide, see you next week, but they have mechanisms for checking in with your clinician in an ongoing way. And we think this is a really, really important component, especially because remember the earlier slide I showed on the pathway where people tend to ramp up their suicidal thinking and planning 6 hours before an attempt. So how can we check in with people in a more regular basis? And this is what I want to end with, talking about some very new work that our group and other groups are doing using real-time monitoring to measure risk of suicidal behavior. And this represents to me one of the biggest limitations in our understanding of suicide. If you think about virtually any other area of science, how do we understand how things work? How do we understand whether the universe revolves around the Earth or we all revolve around the sun presently? How do we understand how chemical reactions work? How do we understand the behavior of other organisms, ants, and so on? What do? In all of these cases, we do really, really careful, systematic observation of a phenomenon of interest. We carefully monitor it, we systematically observe it, and then we generate hypotheses about it and test those out. We haven't done that for suicide. We do it in other areas of psychology. My next door neighbor in my office, the lab adjacent to mine, studies anxiety disorders. How do you study the body's response to anxiety? What he does, he finds, among other things, Rich McNally, who used to be at University of Illinois Chicago, is now at Harvard. He studies anxiety and does things like, Rich McNally does work on anxiety and will do things like find people who are spider phobic, and he has some wolf spiders in his lab, which I find quite aversive, and he brings in people who are spider phobic and exposes them to the spiders, and people get very anxious, and you can very nicely study the body's response to feared stimuli. We can't ethically do that with suicide. We can't bring people into a lab and make them suicidal to study what suicidal thoughts are like. And we haven't been able to go out and follow people around to see what suicidal thoughts look like as they emerge. And so we really don't understand the thing we're trying to understand because we've never observed it. We can't bring people into the psychology laboratory who are suicidal and observe this thing. What we can do, though, is now bring the laboratory to them. And we can do this because in just the past 5 or so years, we've all effectively become cyborgs, right? We all now have these digital appendages that we walk around with in the form of smartphones and smartwatches. Virtually all of us, the vast majority of us in the US at least, and many places around the world, carry these devices around, and they're collecting second-by-second information about our movement, our sleep, our thoughts, our feelings, our activities. And this allows us to do what my colleague Jay Pionella has called digital phenotyping, or a moment-by-moment quantification of the individual level phenotype or physical manifestation in situ, in place, out in the wild, of people using data from the personal digital devices. So for instance, more concretely, can we get data from your phone to measure what it looks like and characterize what it looks like to move into a manic episode or a depressive episode or a suicidal state? Can we capture data from your phone that can do that, or from a device that can do that? And so in a first step, what we did is go online or bring people into our lab who are having thoughts of suicide and put an app on their phone with their permission that asks them questions about suicide 4 times a day. How strong is your desire to kill yourself, your intention to kill yourself, your ability to resist the urge to kill yourself? Asking these questions, again, repeatedly over the course of a month did not increase people's suicidal thinking or suicide risk, but it did allow us to measure what suicidal thoughts look like. So we get a sample of people who say, I have serious thoughts about suicide. We want to see, well, what does that look like over the course of a month? So each of these boxes is a different person, and from left to right in each box is 1 month, and on the vertical axis is severity of thoughts about suicide. And so what do we see? We see a lot of variability within people and across people. So these aren't a flat line. People's thoughts are going up and down, and we see a lot of different patterns. So this is work led by one of my former postdocs, Evan Kleiman, who's now a professor at Rutgers. Evan and I took these data, printed them out on sheets, laid them on the floor of our lab, and stared at them for several hours to see, do we see any patterns in the data? And we didn't. And I hope that you don't either, because we stared for several hours and you're only looking at them for a few seconds. We then took these data, and submitted them to something called a latent profile analysis, which is essentially a computer algorithm that goes in to see are there any latent or underlying profiles in these data? Are there any subtypes, effectively? What I want to show you is what the program saw. The same exact boxes, just reordered. We do see 5 profiles. So shown on top in green are people who, so all of these people say, I have severe thoughts of suicide, I have serious thoughts of suicide. On the scale of 0 to 12, people in green tended to say 0, 0, 0, 1, 0, 1, 0, 1. So they think about suicide, but it's a pretty low level and not a lot of variability. People in yellow, low level, higher variability, so not a lot of thoughts about suicide, but sometimes they shoot way up. People in purple, moderate level, moderate variability. People in red, high level, low variability. They never come down to 0. And people in blue, high level, high mean, high variability. They bounce up and down. Which group is most likely to have recently made a suicide attempt? Which group looks most at risk? Any guesses? Blue? Red? The red group, the high but they never come down, were most likely to have made a recent suicide attempt. This is just one sample. We did the same thing in a second sample, had the same 5 profiles, suggesting this is a robust finding. And what we're doing now is following people out longer term to test, do people move across these profiles? Do they start with the lower severity ones and go to higher severity? Does this red period, is it predictive moving forward of future suicide attempts? We just don't know. We're also getting additional channels of information from people. We're putting apps that collect passive data on their phones. So we collect data from their GPS monitor, from their accelerometer, how much are they moving around, their call and text data, how much are you calling others, how much are people calling you back, how much are you texting, are people texting you back? Not content, we're not recording people's calls or conversations. So we're looking at things like GPS, for instance. So this is one person across 2 days. You can imagine this being overlain on a Google map, for instance. These are data from my colleague, Jay Pionella. And so this is a person. Blue is nighttime, red is daytime. The more a person stays in one place, the more the dot grows to be a bubble. And so this is a person. These are data from his research assistant. She sleeps, this is her home. She goes to work, she spends some time here, she goes back. There's a little blue loop, I don't know if you can see it. She walked her dog. This is a weekend, she didn't get too far from home. So 2 days, knowing that it's a research assistant doesn't tell us much, but you can imagine for non-research assistants, this could be a period that tells us a healthy activation. This could be a depressive episode, the person's not going too far from home. Just by itself, it doesn't tell us much, but in combination with other channels of information, it could be predictive. For instance, we get call and text data from people. These are data from about 24 different people. On the horizontal axis is time, and this heat map shows us how many calls and texts are people making. This is during a hospital stay. So some people didn't make any calls. Some people start making a lot of calls and texts right before they left. Oops. What we find is the more a person is sending and receiving calls and texts, the lower their risk of thinking about suicide on that day. So the more connected a person is, the lower the suicidal thoughts. The less connected, the more suicidal thoughts. We're also equipping people with biosensors while they're in the hospital, at risk for suicide, and then following them out of the hospital, because the period of time when people leave a hospital is a really high-risk time for suicide, and we don't know why. And so we're capturing continuous data from people with these sort of beefed-up looking Fitbit-type devices. They're called the Empatica E4, developed by a company called Empatica. I have no stock or conflict. And we get information about electrodermal activity or skin conductance that tells us about a person's emotional arousal, their heart rate variability, their accelerometer, their skin temperature. And I know I'm running out of time, so in short, we're testing out how well does each of these channels of information do at predicting next day suicidal thinking. And what we're finding is that some of these channels of information, such as accelerometer, how much a person's moving around, can predict with some degree of accuracy whether a person's going to think about suicide tomorrow. So pretty good temporal granularity. And so the idea is, can we use a person's survey data, their passive monitoring data here, their passive biosensor data, to build profiles that can more accurately predict when someone's going to be suicidal in time and place, so that we can then beam them interventions when they need them. What might these interventions look like? Last thing I want to share, we're developing smartphone-based interventions, so we'd still encourage people to go to traditional psychotherapeutic interventions, to consider psychopharmacology, but we want things that can reach people in time and place and that can really target thoughts of suicide and suicide risk. This is work done by one of my recent postdocs, Joe Franklin, who's now a professor at Florida State. What we did in this study was develop this therapeutic evaluative conditioning app. In plain English, what this does is effectively try and classically condition people to have an aversion to the idea of suicide. It's a matching game. You might remember the face game you played when you were a kid, or if you have kids, where you see you've got to turn the cards over, and here's Sally, and you've got to find Sally over there, and you get the match, and you get points, or you get the cards. Same thing here, but you have it on your phone. You see an array of images, and we got a sample of people who were having thoughts of suicide, and we said, we're going to give you this matching game, and you get a penny, let's say, for each correct match. If you're randomly assigned to the neutral condition, you get asked to pair neutral with neutral. So you pair hangers with flowers, for instance. And so you see this array, and then everything disappears except the hanger, and then you've got to tap where the flowers were. If you get it right, you get a penny. And you can play this game, and you actually get paid for your correct matches. If you're in the treatment condition, you get the same thing, but now you're asked to pair suicide-related images, like a pill bottle, with naturally aversive images, like images of snakes or spiders. You play the same game, but we just change what you are asked to pair together. What we want to do is have people start to, in their mind, pair the idea of suicide with things that they're naturally averse to see if we can make people averse to the idea of suicide so they're less likely to make suicide attempts. So it's this brief game-like app. We did 3 randomized trials. We did 3 trials because we did 1, and the results were positive and almost unbelievable, and so we did 2 more. And across 3 trials, what we see is, for people who got the treatment version of the app, nearly 50% reductions in self-cutting, in planning suicide, and in actual suicidal behaviors. Full caveat here, this is over a 1-month period, and then people stopped using the app. We measured them a month later, and those treatment effects went away. So this suggests apps like this can drive down suicidal thoughts and behaviors, and we actually saw the more, using a behavioral test like the IET, the more people developed an aversion to self-injury and suicide, the bigger their decrease in the likelihood of that behavior. So it seems like the app was working for the reason it was working. 1 month probably isn't a big enough dose. And so what we want to do, and what we're planning to do in future studies, is test out larger doses for longer periods of time to see if this is a way to help drive down these behaviors. And this is actually freely available in the App Store. It's called TEC, or Tech. So if you want to get access to this as well, you can get access to it, play with it. You just don't get the pennies for correct responses in the free online version. So I want to end there with just a few take-home points that I hope to have conveyed. One is that suicidal thoughts, non-suicidal self-injury, suicidal behaviors are relatively common in youth and in adults as well, 9%, 15%. So these are behaviors that we see with some degree of regularity, unfortunately. So if they're present, that's not so abnormal. The highest risk for transitioning, again, from suicidal thoughts to behaviors is that first year after onset. The more risk factors a person has, the higher their risk. Really important to keep in mind, there's no one thing that does it. It's the accumulation of factors right now that is our best prediction. If you think someone might be thinking about suicide or engaging in non-suicidal self-injury, I would implore you to ask them about it. And ask them more than once if you have that concern repeatedly. There are effective psychological treatments out there, such as DBT and CBT, and there are places where you can find them. And we are working on the research front on new ways of using people's behavior, their neural responses, smartphones, apps, biosensors to try and really harness new technologies to get better at detecting risk of suicidal behavior, monitoring people's risk, and developing and deploying interventions to really try and drive down this really devastating set of behaviors. Thank you again so much for your time and attention and for inviting me, and I look forward to trying to answer any questions you have.